In this video, we will demonstrate the senior author's technique for camera resection deemed a two-tier resection. Tier 1, demonstrated in the second picture, aims to set the depth of resection and restore head-neck offset. Tier 2 then resects the remainder of the cam lesion to the same depth. The procedure is performed in the supine position on a post-free hip distraction table with portals as outlined here. Prior to start of the procedure, the template of resection is projected in the OR suite. We start the video after the diagnostic arthroscopy and labral repairs have been performed. To begin, we identify the articular cartilage margin and identify the physeal scar on fluoroscopy, which will be the proximal extent of our resection. With these landmarks identified, the two-tier resection is begun. The Tier 1 resection is begun approximately 1.5 burr lengths distal to the articular cartilage margin. In doing so, it is important to identify the lateral retinacular vessels and ensure their safety during the resection. Resection then proceeds at the location previously identified as 1.5 burr lengths distal to the articular surface. Tier 1 resection continues until appropriate depth as well as restoration of head and neck offset is achieved. This is confirmed with fluoroscopy. After satisfactory resection of Tier 1, attention is then turned towards the remaining cam distal to the first tier. The goal is to match the depth set by the first tier. This is accomplished with a consistent sweeping motion with the burr on reverse to allow for greater control and minimize risk of over-resection. At the completion of the Tier 2 resection, attention is turned to the femoral neck proximal to the first tier. Here the burr is utilized again to recreate the sphericity of the femoral head. This portion of the video demonstrates the importance of choosing an appropriate start point. Too proximal of a start point will not allow for recreation of the spherical head, which could lead to potential loss of suction seal, particularly in deflection. Once satisfied with our resection, we then inspect the resection both directly and fluoroscopically. In this instance, it was felt there was not adequate restoration of the head and neck offset on fluoroscopy. Thus, the process of the two-tier resection is then repeated in a similar fashion. Briefly, this begins with Tier 1 to set the depth of resection and attempt to restore head-neck offset. Tier 2, as shown here, then resects the cam distal to the Tier 1 resection. Again, during this period, fluoroscopy is utilized to ensure appropriate resection. After completion of Tier 2, again our attention is turned proximal to the Tier 1 resection with the goal of restoring the sphericity of the head. This portion of the video demonstrates another critical concept for this technique, which is the importance of the visualization of the osteoplasty in multiple views, which allows for optimal resection and contouring. Here we demonstrate another view frequently utilized by the senior author, deemed the up the neck view, in which the arthroscope is rotated 90 degrees to look directly up the neck at the head-neck junction. This allows yet another perspective of the proximal resection in order to ensure a smooth transition is created along with the spherical head. Final resection of the cam is confirmed with direct visualization and fluoroscopic imaging. Not shown here, the hip is then taken through a dynamic range of motion to ensure no residual impingement occurs.